Hello everyone. I'm Zara Saeed. I'm a fourth year biology major, and over the past year, I've developed this project with with Dr. David Lowe, who is the Senior Associate Dean of Research at the UCR School of Medicine on the attitudes and approach of faculty and students toward racial bias in medical education. So for the background of this topic, in recent years, there's been an increased emphasis placed on persisting racial bias in the medical field. And it's important to acknowledge this implicit racial bias that is present in our current systems because it may lead to disparities in medical school admissions, patient care, faculty hiring, and opportunities for growth. And understanding how race is presented in medical education may explain how racial bias is perpetuated. Okay, so for the problem, a recurring problem that happens in medical education is overemphasizing the role of race in the diagnostic process and susceptibility to disease. So a lot of times race can be used as a clue or a hint to the correct answer on a board-style exam question in medical school curriculum. And while these automatic associations of race might help medical students answer test questions correctly or learn the material, these stereotypes may lead to increased misdiagnoses. Often race is listed as a risk factor for disease, and this is a problem because it fails to consider variables outside of the patient's race that may increase their susceptibility to disease. So for example, sickle cell anemia or sarcoidosis are often portrayed as primarily affecting Black people, but they aren't the only group affected by it, and there may be other variables that contribute to its prevalence in that population. Additionally, the phrasing of questions from step 1 of the board exam can frame whiteness as the norm and inaccurately attribute genetic mutations to specific races. So additionally, the way that race is approached in the curriculum can alienate students. So some medical students might feel uncomfortable with how statistics about health outcomes for different races are presented. Often professors will be prioritizing efficiency as much as possible, and they might be unaware of how students feel when hearing these jarring statistics. So, for example, one study found that several Black women in medical school felt overwhelmed hearing statistics about poor health outcomes for Black female patients, while professors seemed unfazed by them and didn't linger much on the topic. So, for some possible solutions are proposed in much of the literature. So those would be adjustments to the curriculum that might improve upon this issue. So while race is important in medicine, when it's mentioned in curriculum, it should be relevant to the conversation, and it needs to be contextualized to avoid stereotypes. So for example, framing race as a risk factor for disease would kind of be a little bit too broad, and it would be more helpful to discuss what specifically makes those populations vulnerable. Many studies suggest the use of ancestry instead of race on forms and in the curriculum could be more accurate indicator of susceptibility than using race, especially because it ignores other factors that could contribute, as well as ignoring the increasing numbers of multiracial or mixed individuals in the population. So now with that background information in mind, I'll move on to the research aims and predictions for this study. So for the research aims, our main goal is to understand how racial bias and discussions of race are framed in medical school curriculum. We did this by surveying faculty and students from the UCR School of Medicine. We were interested in comparing attitudes toward race between faculty and students, as well as understanding how the different experience levels of faculty might influence the attitudes about this subject. So our main question was, is race framed as a risk factor for disease? And that was kind of our main focus of this study. So the future impact of studying this topic could lead to changes in the curriculum so that patients can receive a higher quality of care regardless of their racial background. So for the predictions, we predicted that students and faculty would have different attitudes toward race due to their different life experiences, and faculty with fewer years of experience would have attitudes most similar to students than other groups because they might have experienced similar education about topics like race in medicine than professors that have been practicing for a longer period of time. So onto the methods section of this study, we surveyed, we distributed 2 surveys to the UCR School of Medicine, one for community faculty and one for students. We were able to survey 25 students of the 328 enrolled during the 2021-2022 academic year. And for faculty, we were able to recruit 90 participants among the approximate 1,200 community faculty. So for the survey development, we performed a literature review to better understand the topics and understand the impacts of implicit racial bias in medicine and some possible solutions to these systemic issues. Next, we developed survey questions in multiple rounds. This is where I worked with my faculty mentor to develop questions that would cover a range of topics relating to opinions on race and its relevance in medicine. So 29 questions were developed for the student survey and 24 questions for the faculty survey. So next, for the distribution, faculty and students were sent the link to the survey through their institutional emails. And that was after the IRB approved our survey. And the analysis was looking at the responses that we received and compared attitudes among different groups. So moving to the results of this study. So here are the demographics of the students that were surveyed. So in general, the UCR student population is highly diverse compared to the student populations of medical schools across the US. They're not representative of all students. And this sample of students that responded have some racial groups that were overrepresented compared to the overall population of students at the UCR School of Medicine. But as you can see, the white and Native Hawaiian groups are slightly overrepresented, while Asians are underrepresented in this sample, with 24% of those participants identifying that way in the student survey versus the 32 that are present in the overall population. So students who selected other were slightly underrepresented as well. And it's also important to note that the UCR School of Medicine demographics doesn't have a category for Middle Eastern or North African like our survey does. So they might fall under white or other, but there's no real clear understanding of where they might fall within the demographics. So for the professor demographics, there's the different levels of experience shown here. So majority of our participants had more than 20 years of experience, and additionally, 97% of the clinical faculty were surveyed. 97% of our sample was clinical faculty, and then 56% were male and 42% were female. So when qualifying race as a risk factor for disease, we ask questions in both the student and faculty surveys aimed to understand if race was established as a risk factor for disease in the medical school curriculum, and if opinions about this question were similar to between faculty and students. So questions indirectly and directly asked this. Some were phrased more indirectly to gauge whether race was important for diagnostic purposes and disease susceptibility. So this first figure on the left shows the faculty level of agreement with the statement that race is a risk factor for disease. And most professors agree or strongly agree with this statement. And the student survey had a similar question asked, but it was phrased how frequently race has ever been listed as a potential risk factor for disease in your medical school curriculum. So most of them said that they agreed to some extent that race was mentioned, either sometimes or very often were the most common responses. So it was often discussed as a risk factor for disease. And these responses show like a consistency between the two surveys, that there is in fact an emphasis being placed on race being a risk factor for disease, and it can be seen directly here. So for this next figure, it shows the undecidedness among professors about race as a risk factor for disease. So this figure shows the percentage of participants from the faculty survey that selected undecided when asked if race was a risk factor for disease. So 27% of professors with less than 5 years of experience selected this, which is the most out of any of the other categories. So it's clear that this category with professors with less than 5 years of experience were more undecided about this issue than other professors. And that's a trend that we noticed throughout their responses to questions in this study, where less experienced faculty were more unsure than faculty with more than 20 years of experience. So for this next figure, it shows responses to the statement that medical treatment should be adjusted based on a student's race. So listed in blue is the student responses, and in orange is the faculty responses. So student responses were largely undecided, with 52% of the participants choosing this answer. In contrast, the faculty responded that they mostly agreed with the statement. And then again, we compared the responses between faculty of different experience levels, and 27% of the professors with less experience were undecided. But so were 20% of the professors with more than 20 years of experience. So this kind of shows the level of undecidedness. While it's not the same as students, it might suggest that faculty opinions may influence students' flexibility or undecidedness about this topic. So when asked about the importance of connecting race with susceptibility of disease, students and faculty had similar responses concerning its importance. Professors seem to emphasize it more than students, with 63% agreeing and 40% agreeing, but also more students strongly agreed than professors. So it's important because it highlights another instance where attitudes of faculty toward race might potentially influence students' attitudes. And again, with this question as well, 27% of the faculty with less than 5 years of experience were undecided about its importance. So moving on to the discussion of these results, I want to first focus on, before I discuss the conclusions, I want to discuss how there's some limitations to the study. So using a convenient sample from the UCR School of Medicine, like I mentioned before, the student population is not representative of the broader populations across the US. And with our limited sample sizes, we can't really generalize our findings to all medical students or all medical schools. So that would constrain our ability to do that. As for the conclusions, this study is qualitative and descriptive of attitudes of faculty and students about race in medical education, specifically regarding race being described as a risk factor for disease. So although the sample size of the study was smaller than we hoped, valuable patterns can be still seen through the participants' responses. For both student and faculty responses, it's clear that race is framed as a risk factor for disease in the medical school curriculum. While not asking like the direct questions about race being framed as a risk factor for disease, we can still discern a pattern where race is connected to disease susceptibility. So there's also a clear difference in responses between the two groups, and student responses are largely undecided on adjusting treatment based on race. And then lastly, increased undecidedness among more inexperienced faculty and students indicates flexibility of attitudes. Excuse me one second. So in future studies in this topic, adjustments can be made to better understand attitudes towards race in medicine. Larger sample sizes will allow for this, for a more representative sample, and for statistical analyses to detect significant differences in responses. Overall, the premise and goals of the study, paired with the larger sample size, would allow for more unambiguous interpretation of how attitudes of faculty and students about race in the medical field are related. So to avoid using, so some adjustments to the curriculum, you could avoid using race as a hint for diagnostic disease test questions. Curriculum at UCR does show associations between race and susceptibility, but there is some evidence that there is proper context presented with this, which can avoid some of the cliches and stereotypes associated with conflating race and susceptibility to disease. There's also a pattern of uncertainty, as mentioned before, among faculty with less experience, and that indicates flexibility, where adjustment to the curriculum could be possible in the future to reduce bias overall as much as possible. So, and then here are just the references that I use for my literature review. And I also wanted to take the time to acknowledge and give special thanks to my faculty mentor, Dr. David Lowe, for his guidance and continued support throughout the development and completion of this project. His mentorship has, provided me with invaluable advice, and I will continue to take that with me in my future research and career. And I also want to thank Rosemary, Irina, and Monique for their help with distributing the survey, as well as the honors program and the faculty for allowing me to do this research. Thank you.
Excellent job. Let's go ahead and give